Hello, everyone, and welcome to this program on multiple sclerosis, which is being broadcast on Facebook Live. And we want to welcome everybody who's here in New York to the program. I'm Stephen Krieger, a neurologist at the Multiple Sclerosis Center at Mount Sinai here in New York. And I'm very happy to welcome everyone to this program. We're going to be talking about the latest MS research updates from 2017, things that are, I think, of interest to all of us that have been happening this past year. I want to welcome our Facebook Live audience and say that we are going to be taking questions from you. So if you have questions as we go, you can type them in there on Facebook Live, and we will try and address them either during the program or certainly at the end of the program. So I hope you'll watch with us for the whole time. So let me let our panelists and our discussants introduce themselves.
Hello, welcome everyone. Thank you very much for having me here today. My name is Jong-Mi Lee. I'm a nurse practitioner at the Stanford Healthcare University Medical Center. I work with patients with MS for the last 10 years and also a certified MS nurse.
Hi everyone, I'm Claire Riley. I'm an MS neurologist. I'm the medical director of the Columbia University MS Center and an assistant professor of neurology at Columbia.
Hi everyone, I'm Rachael Stacom. Like Jong-Mi, I'm a MS certified nurse. I'm a nurse practitioner. I have some fans, this is nice. I work at Independence Care System and also the Bronx, Lebanon MS Center. And I'm really happy to be here with you guys today.
Well, welcome everyone, and thanks to those of you who are here and to those of you who are watching. Couple of disclaimers. We're going to talk a little bit about new research, and whenever we talk about new research, that's going to include things that are not yet approved for use in this country, things that are off-label, things that are interesting for us but not yet available. And some of these things have been presented in meetings as abstracts, which means they're out there in the world for us to consider, but they haven't yet been peer-reviewed or proven. So, take the things that we're saying a little bit with a grain of salt because they're brand new, but that's sort of the goal of this program. So, we tried to organize our topics. There's so much that we could talk about, and it was really hard to narrow it down. But we tried to organize our topics into a couple of different categories of interest. So one is an update to how we diagnose multiple sclerosis at all, something called the diagnostic criteria, and how we think about what the disease can look like in different people. So that's our first topic. Our second topic will be new research and outcomes in relapsing MS. And so we have a bunch of data and studies on relapsing MS that we'll talk about. And we have new data and studies on progressive MS, which is, of course, a very important topic for all of us that we'll discuss. And then we have a section on well-being in MS, brain health, wellness, diet, things of that nature that we're constantly thinking about and being asked about that we'll talk about. And then finally, if there's time at the end, we each picked one random other topic within MS, not that random, but one other topic to mention of interest if we have time at the end. But if you guys have lots of questions, we're more than happy to take your questions instead of that. So we're going to begin by talking about new diagnostic criteria. So why do we have diagnostic criteria in the first place? MS is obviously an incredibly variable condition. No two people with MS are quite the same. And as clinicians, that makes it challenging sometimes to arrive at a definitive diagnosis and to explain clearly to someone that they have MS and to try to do that as early as possible. And for that, we rely upon diagnostic criteria, which are created by an international panel. And we've had the same diagnostic criteria for MS for the last 7 or 8 years. And this year, we have a brand new version of it called the 2017 McDonald criteria. And maybe we can turn it to the panel and say, what's new in diagnosing MS in 2017 that's different than it was before?
Yeah, so one of the things that we've kind of brought back that was there before in the diagnostic criteria is actually looking at the CSF and spinal fluid. So now we're going back to looking at the spinal fluid, and if there are any bands, oligoclonal bands in the spinal fluid, then we can make the diagnosis of MS in a patient who's had a one-time event from CIS. That's a big change because we didn't really look at that before. But what this will allow us to do now is that patients who are diagnosed under the category of CIS, we could make a faster diagnosis to MS and get these patients on treatment earlier.
And maybe just to speak off that for a minute, the big picture is when you diagnose MS, you want to identify both dissemination in space and dissemination in time. So dissemination in space, meaning different areas in the nervous system are involved, either by MRI or clinically. So that might include, for example, an optic neuritis affecting the optic nerve, and a symptom of double vision on right gaze, implying a lesion in the brainstem. So dissemination in space is one aspect, dissemination in time, meaning that these two things didn't just happen at the same moment in two different places, but that it is clearly a recurring issue. And so the nuance here is that the oligoclonal bands imply dissemination in time. What are oligoclonal bands? I often am asked this. So essentially, these are proteins that are produced by B cells. Our B cells are among your immune system warriors, and they produce antibodies, and they produce antibodies in the peripheral blood that circulate and help keep you healthy and fight off viruses, for example. And in the MS population, we often see, very often, but not always, often see a population of immunoglobulins or proteins produced by B cells that are living in the central nervous system. So when you test for oligoclonal banding, you make a comparison between the blood and the spinal fluid and see, is there an independent or sort of rogue population of B cells that have set up shop in the central nervous system? And it's that implies that dissemination in time. So that's the rationale. As Jong-Mi explained, I think our goal is to get the right diagnosis, to get it as early as possible, but to not mistake a one-time event for a lifetime disease that we need to treat in perpetuity.
Another thing that the diagnostic criteria helps us with is what the MRI for someone with MS looks like, and how do we identify those lesions specifically. So I'm going to use that as an opportunity to answer a question from Facebook. Lynn from Facebook asks, how do you tell MS lesions from other types of lesions and spots that we could see on an MRI scan? The diagnostic criteria helps us a little bit with this by defining the specific places in the brain and spinal cord where MS lesions are most likely to go. And it also helps us to define their size, their shape, and their particular appearance on MRI. So it gives us kind of a framework to look at an MRI scan and say, yes, these spots do meet our diagnostic criteria, or, I'm suspicious that somebody might have MS, but their spots don't quite meet our diagnostic criteria. So it helps us in that way to look at them more specifically. And then one can go further and describe a lot of other nuances about what makes an MS lesion look the way it does. But this is how the diagnostic criteria helps us with that question.
The other key, though, I think also is that it's not just the image. We're not being outsourced entirely to radiology just yet. You have to take these lesions in context of the human being in front of you, and that person's symptoms, their neurologic exam, the supporting data. We retain in our diagnostic criteria the caveat that there must be no better explanation for the clinical symptoms and the imaging findings. So it's not in a vacuum that you can say that spot is definitely an MS spot. Right. It's not so simple.
Yeah. I'll just add to that I think it's really important that that we're continuing to look at this, because the criteria was last updated in 2010, so we're still learning, and as we go along, we're still refining, because as everyone said, we want to make sure you get the right diagnosis at the right time, so we can control this disease.
Another question from Facebook relates to that. Avi asks, what about the radiologic isolated syndrome? Have you guys heard this term, RIS? And what that means is that the MRI looks like multiple sclerosis. It has the lesions in the places that we would expect to see them. in someone who's never had any MS symptoms at all. Now that might seem counterintuitive on the face of it, but we know that somebody with MS might have one symptom, maybe optic neuritis, maybe numbness in an arm or a leg, and then when we do the MRI scan, we see half a dozen lesions. Well, so most of those lesions didn't cause any symptoms at all. So it's certainly possible for many of the lesions that someone has to not sort of cross the threshold and cause something that we would know about, that you would feel. So RIS, radiologic isolated syndrome, is the way we describe that. And that hasn't changed. This was one of the questions. That hasn't changed in the new criteria. The question was, would we do a spinal tap and get spinal fluid in that setting? We might, because we're trying to figure out what's causing those spots, and spinal fluid could help us with that. But someone who has RIS, never had a neurologic symptom, we still would not be able to say they have multiple sclerosis. As Dr. Riley said, it's not just the MRI kind of in a vacuum. It has to make sense with what the person has experienced to give us the certainty to tell someone that he or she has MS.
And this is under, an area of active research. So, for example, right now there's an active clinical trial called the ARISE trial, where individuals who have that radiologically isolated syndrome, an MRI that very much looks like MS, we might show it to our medical students or nursing students and say, these are periventricular lesions, these are juxtacortical lesions, see the pattern, this is very suggestive, but without symptoms. So this study is trying to answer that very question of management. And it's testing immunotherapy, dimethyl fumarate, versus placebo, looking at time to first relapse. Not time to MRI change, because we know these people already have MRI changes, but is treatment with an immunotherapy, in this case dimethyl fumarate, reducing the likelihood or changing the needle of the individuals that will go on to develop clinically definite multiple sclerosis. So I think a very important study.
I just wanted to add, what's very cool now is that MRI technology is advancing so quickly that on the first question about how do these MS lesions look, you could actually drill down and you just see that irregularity of the border. It's not a smooth border, round circle, but you just see a very nice kind of irregular border, almost like a 3D shape of some of these lesions.
That's right.
And the new criteria also include cortical lesions. I mean, this is a complexity too, is that all the time our mouse traps are getting better, right? And so we're catching more mice, right? We have stronger MRIs. I've looked side by side before at an MRI done on a 1.5 Tesla magnet and a 3 Tesla magnet. And then you throw in that 0.7 low field strength open MRI that doesn't show you very much. And you might see a totally normal scan, modestly abnormal scan, and a significantly abnormal scan with those 3 different field strengths, and then throw in did the person move during the scan or not? As we get better tools, we have to refine our criteria. We also have to interpret our remote clinical trial data in the context of what the McDonald criteria were at that time. So very different patient might be enrolled in a study for relapsing remitting MS in 2017 with these criteria versus 1995, right? So it's a different landscape.
One of the other things that's changed, of course, for us in how we are approaching treating MS is what our goals are. Now that we can make this diagnosis early, we know that treating people with therapies can help to prevent disability. We're getting, in one way, more and more both hopeful and also aspirational, I think, in what we're trying to achieve with people who are being newly diagnosed with MS. So for the last couple of years, we've had something that gets called in our field NEDA, no evidence of disease activity. Have you guys heard this term? No. Some of you. So the idea there is we're trying to prevent relapses. We're trying to prevent new lesions on the MRI scan. And of course, we're trying to prevent any neurologic changes and disability from happening. And when we achieve that, we call it no evidence of disease activity, no relapses, no new lesions, no new disability. And that's become sort of one of our aspirational goals that we're trying to achieve. This past year, there's a new version of that, which is in some ways even more aspirational, because I think better than we do, that what your clinician does in the office with you, squeezing hands and touching nose and fingers and using tuning forks doesn't necessarily tell us how are you in your real life. How are you with your function and your abilities? And so one of these new ways of describing MS disability and the attempt to prevent it is called, it's got a silly name, but it's called NEPAD, No Evidence of Progressive or Active Disease. And we were talking earlier about how it has a little bit more of a person-centric kind of information in it. Maybe, Rachel, you want to tell us about that?
Sure. So when Stephen first talked about NEDA was really, when we're talking and neurologic changes that can occur from that, we use a scale called the EDSS. And there are some limitations to that scale. And as you know, I was saying to Stephen before, it really doesn't always correlate with how people are getting through their day. So in NEPAD, it talks about things like the 9-hole peg test, and I don't know if anyone has gone through that, but really looking at fine motor function, right? So those skills that you rely on to button your clothes or zipper or cook, that can really impact your life if you're losing that coordination. So these are things that are included. Looking, and they're really measurable. So instead of having this this definition that you really need to know neurology to measure changes, this is something I can have a dialogue with the patients about. This is what we're talking about. We're looking at, have you had a change in your ability to do that 9-hole peg test? Has there been a confirmed change of 20% in your ambulation? So things you can we can have a rich dialogue about, which I think is really important.
I think that's very important. Trying to coordinate our questions from Facebook and answer your questions and talk at the same time is very challenging. So from Facebook, one of the questions that we've just been asked is to think long term about our treatment and to say, what does the life expectancy look like in multiple sclerosis? And then a second question, that was from Biswajit, and another question from Ismail was, what's the prognosis in general for this disease? And I think those are really hard questions to answer. Maybe I'll give you a thought or two, and then we'll see if my colleagues can say a thing. I think prognosis now is better than it's ever been before. And we're trying now to take this long view of what preventing all these forms of disability could look like. But prognosis for people who've had this disease for a long time is still a bigger challenge for us because we haven't yet developed the ability to turn it around.
So I think we've always let our patients know that having MS does not shorten your life expectancy by a big number. Definitely can make life very complicated, and the complications can cause additional issues. But with these new therapies, and as we look at some of the, as we talk about some of the other topics here, is that early treatment really can affect your long-term disability. So now, just like as Dr. Krieger was saying, in this day and age, with the type of treatments that we have, I mean, we're looking at a much better prognosis. We're looking at a better quality of life long-term. And with all this research that's going on, we're very, very hopeful that the patients will have even better quality of life.
I'll just add one thing. One thought is that there has been some data to show not necessarily MS impacting the lifespan, but comorbidities, other disease processes that are going on. So as we talk later today about health and wellness, really the importance of doing what we can to play a role in our own health, like what we eat and how we exercise becomes very important.
The questions about prognosis also relate to some of the data that we wanted to share with you, which came out this year. It's very hard to talk about prognosis in individual people or in a few people or even in one's own clinical practice. What we really need are very large populations of data that we can look at and see, okay, I know how my patients are doing, but how is everyone with MS doing, to really help to answer that question. So there was a study this year done by a group out of Australia called MS-BASE. And MS-BASE looks at patients from dozens of places across Australia and the world and allows us to look at how thousands of people with MS are doing. And I thought this was one of the most positive or optimistic pieces of data that came out this year. So this MS-BASE study looked at around 2,000 patients, more than 2,000 patients, followed for many years, and found that patients who were being treated with disease-modifying therapies had a 40% decreased chance of developing increasing disability over the long term. And furthermore, people who were treated had a similarly close to a 40% chance of improvements in function after they got started on treatment than people who did not. Now, it's hard to promise an individual person 40% this or 40% that, but I think what we feel, and at least I can speak for myself, is that there's some meaningful good that comes from using MS therapies and using them early and preventing relapses and disability. We know that the people that we're treating now seem to be doing well, better than a generation ago. But this kind of data helps to support that, and I found it very positive. I don't know if you guys have other thoughts on it.
Yeah, I mean, looking at this data, again, just points to the fact that early treatment can affect long-term disability outcome. So it's very encouraging to see this large population size and that there is a 40% reduction and that patients do well. The other topic that always comes up is, how do I know if this drug is working for me? So it's hard, and I say, well, I can't have a placebo you. So it's hard to tell you on drug and off drug how you will do in 20 years or 30 years or 40 years. But having this kind of data does point to the indication that possibly this early treatment really can prevent long-term disability.
The other thing is, there may be other knock-on effects to the individuals in the MS space that were on immunotherapy. They may be more likely to be engaged in physical and occupational therapy. They may be more likely to be active in their social network within the MS space. So an analysis like this, I think it's helpful. I don't think it really isolates completely what the medication effects are versus the other kinds of ways that you can be engaged in treatment. So if you're in a situation where, because of the course of your disease or other potential risk factors, medication isn't being recommended for you, it doesn't mean that there's no hope for improvement or wellness, and that there are other things within the MS centers where you receive care where you may, find benefit.
So another thing that we're trying to do in our field, I think, is to describe MS and to understand it in a more individualized way. So even the categories of relapsing remitting MS, secondary progressive MS, primary progressive MS are somewhat arbitrary, and they don't, I think, do a perfect job of describing what an individual's experience of this disease is. People ask us all the time, what kind of MS do I have? And I think that's a very reasonable question because we've described it in these types. But on a deeper level, I think there's so much variability in how people with MS are and how it affects them that I don't know that the categories necessarily do justice to an individual person's experience. It's with that in mind that I've worked on something that I've called the topographical model of MS over the last few years. So I was going to tell you a little bit about some data from that from this year. The topographical model, if any of you have seen what a topographical map looks like of sort of peaks and valleys, it attempts to show that where the lesions are in MS matter. They cause particular symptoms in particular people, and no two people's map of their MS is exactly the same. And so the idea of describing MS as this map of disease, I think, allows us, or helps me anyway, to think of an individual person's disease course, not just as relapsing, remitting, or progressive, but in what way, with what symptoms, with what things that I'm looking for. So I proposed this topographical model, and it looks like a swimming pool that drains, if any of you have seen it. I've used it to try to teach people about the disease, the idea that a lot of MS hides under the surface. So it looks like a swimming pool because there's the notion that we see some things above the surface of the water and other things we don't. They hide below and we can see them with MRI scans. So this year we looked at real patients, our patients from our center that have been followed for 20 years, and showed that, in fact, we do think we can map them in this model. It's been a kind of a conceptual idea and a way of teaching until now. But this year we showed that we could actually study, real people with it, and it seems to work. And now my next step is to try to make that even more meaningful, so one day we'll be able to actually map our people in this model and perhaps be able to tell something about their disease course, their likelihood of disability that we can't tell right now. I don't know if any of you have used this in your practice or to help explain things to patients.
It's a great visualization. It really helps when we're, thank you very much, Dr. Krieger. It really helps when we're trying to explain relapses and disease progression over time, because both of those can actually coexist in this water tank. It's a very nice way to show just how the MS is functioning and how severe it is to have spinal cord lesions in this map.
Got it.
Yeah, I agree. I now have, I'll say to people, manage your tank, take care of your tank, make sure your tank is filled to the best, the highest capacity it can be. It also helps me explain things like Utaf's phenomenon and how symptoms appear if there is an increase in temperature in your body. Symptoms that had gone away might reappear. Or when you have a pseudo-exacerbation, meaning a return of previous symptoms. So the tank can be helpful. I wish we had it here to show you, because if you don't know it, you might say, well, what does that mean?
It's on the internet.
But it is on the internet, and I think, I know it comes up nicely on an iPad, right? So,
I mean, I think trying to teach our patients to understand this disease as best we can, I think, is in many ways half my job, and I hope the model helps to do that. I want to take a question from Facebook which relates to how we teach and speak to our patients. So this is a question from Lynn, who asks, my doctor told me that I have MS, and now another doctor tells me that I don't. What am I supposed to do?
Sounds like she needs a tiebreaker.
Yeah, she needs a third opinion.
So this comes up. It's not uncommon, and maybe some of you in the room or in our live streaming audience have had this experience other than Lynn. I think that the most important thing that you can do is get the right diagnosis. And I think that sometimes you take two very reasonable clinicians and you present them with the same data, and they may make two different conclusions. So it doesn't mean that one is ill-trained and one is brilliant, but it might mean that they're just interpreting things slightly different. There is art in medicine as well as science, and some combination of both. So what I think I would recommend is probably making sure that you're seeing somebody who's trained in multiple sclerosis. I don't know of these two providers what their background is. I think that it's important from the patient perspective to feel that you're being heard, and to have an explanation of diagnosis that makes sense to you. And so that might mean seeking a third opinion from a tertiary referral center for multiple sclerosis. If that's not available to you immediately in your area, I think that the conclusion that I would go with is the one that can be explained to me and makes sense to me. So that's what I would do. I don't know if you know.
Yeah, I mean, I would say if there's uncertainty to a diagnosis, there might really be uncertainty. And some people are on the cusp of being clearly, making an MS diagnosis. It may be that the person who tells you that you do have MS is right. It may be that the person who tells you that you don't have MS is right. And I think the best thing you could do to what Dr. Riley said is ask why. Ask your clinician to take you through their decisions, their decision making. Why does this person say, yes, you do have MS and should be treated? Why does this other person say, I'm not sure? There may be very good reasons for both ends of that. And I think asking why, having your clinician take you through their reasoning is good. Any clinician that balks at answering why have you come to this conclusion, I would worry about. We're all pressured for time. We're all, under the gun. But we owe it to our patients to explain our thinking and to make time to do it and to set up an appointment just to do that if that's what it takes. I think that's really important.
And there's nothing wrong with getting a third opinion as well. And hopefully the new diagnostic criteria can aid in making that correct diagnosis.
Just one last point. I just want to say, it's really important that everyone is their own self-advocate, and that you're out there. If you don't feel right about something, keep going. and get the answers that you need. So don't settle just because someone said that if it doesn't feel right to you.
So I'm going to pause for a moment and say we've gotten through precisely a fifth of the information we wanted to get through in precisely half the time. So I think that means we're running behind. So I'm gonna move us forward just so we can hit some of the high points a little bit. And for the Facebook audience, I'm gonna come back to your questions, but I'm gonna try to get us through a little bit of the content so that we hit some of the high points. They relate to many of the questions. So let's turn to some updates in clinical trials and new data in relapsing MS. So we have, as you guys all know, over a dozen medicines that are approved to treat relapsing MS, but we still have many unmet needs. And so there is a medicine called fingolimod that's been out for 7 years, and it's an effective agent. It has certain complexities to it. And now we're starting to see data from several next generation versions of fingolimod, in essence, ways that medicine has been refined. And so one of them is a medicine called ozanimod, which had several, it doesn't have brand names yet. We're not using any brand names anyway, but these are unapproved medicines that have had successful clinical trials. But fingolimod is the first one that's out, and ozanimod is the second one, which has now come through a couple of clinical trials called Radiance and Sunbeam. Who wants to take us through some positive data there?
First, I'd like to congratulate them on those great acronyms.
Yeah.
Those are really terrific. I think we can all just say those are good. It gives you a nice feeling. So these were 2 positive phase 3 studies with this oral disease-modifying therapy, sort of a next generation of fingolimod. It was evaluated against interferon beta 1A. And showed significant reduction in relapses, and also showed a reduction in the rate of brain atrophy. So once you're 30, all of us, whether you have MS or you don't have MS, you have some reduction in your brain volume. People with MS tend to have a slightly faster rate of atrophy than people who don't have MS. And so one of our goals, radiographically, when we're treating MS, and particularly when we're looking at these fancy MRI outcomes in clinical trials, is to see that the rate of atrophy approaches the healthy control rate of atrophy. And that was seen in this study, and that was very encouraging, I think. So in terms of timeline, my suspicion is that we'll see FDA review of this agent in this coming year. And the other difference from fingolimod to be aware of is that fingolimod requires now a first dose observation because it can slow your heart rate a little bit and occasionally make people feel lightheaded. So some may be familiar with this. It's about a 6-hour observation. And it can be pretty onerous, especially if you live in a remote area of the country where you don't have access to a center where they can observe you or something of that nature. So the complexity and nuance with ozanimod is that they actually do a dose escalation over when you start the drugs. You start at a lower dose and step up, and that may obviate the need for that first dose observation, which would be exciting.
So that's one trial and one medicine. Another one which is totally different than all of that is something called OPA Cinema, which has a slightly better colloquial name. We've been referring to it as anti-LINGO for the last couple of years. So LINGO is a molecular way that the myelin cells know when to stop growing. And so anti-LINGO is a way that we could stop that stop sign on myelin growth and maybe encourage myelin to start growing again and start growing back. So of course, if MS is a demyelinating condition, if we can encourage the existing myelin cells to start regrowing again and grow back, that would be progress in a way that we haven't had before. And so this was studied in a trial called Synergy, where people who were being treated with an injectable interferon had this medicine added on versus placebo. So everyone's treated, but the question is, does this medicine help restore function better than placebo would? The answer is complicated. Anyone want to take the lead on the answer to that question? Nobody wants to take the lead. Dr. Riley, take the lead on it.
I will do. So the results showed this inverse or upside down U, where the lower dose did not seem to be effective, the medium dose seemed to have some efficacy, and then the higher dose did not. But this hint of efficacy was enough for the investigators to go forward with another study that will hopefully refine the dosing, potentially lead to a clear outcome. I think that we would love to see an agent that we could use in combination with our existing immunotherapies that would potentiate remyelination and have that on board as early as possible. I mean, this was previously studied in people who were having an acute relapse, specifically of optic neuritis, to see if you added this agent early on, could it be effective? And what we learned from that study was maybe it needed to already be on board, maybe when that event was starting. Right. And so the trial design, for the next study will be interesting to see. But it's certainly an appealing model and something that, as we think about addressing remyelination as quickly as possible, because once that neuron that's coated in the myelin jacket, if that neuron is exposed in a sort of a toxic environment and that neuron actually dies, no amount of remyelination is going to bring that back, right? So there is clearly a critical window.
Yeah.
And it really supports trying to have a multi-pronged approach now for MS. It's not just taking one therapy to reduce inflammation, but what else are we doing to protect the neurons and the brain, and then also now remyelinate parts of the brain as well.
Yeah, and that relates to one question from Facebook from Stephanie that asked about prevention, not just treatment, but prevention. And I think this idea that Jong-Mi said of layering this multi-pronged approach to treatment is going to be the future for us. We want to prevent relapses, to be sure. We want to build back myelin if we can. We want to foster building one's reserve, which we'll hopefully have time to touch on a little bit, to try to maximize someone's neurological function and life function. So it's not going to be as simple as one medicine anymore.
But the other thing, I'm not sure if this is what Stephanie is alluding to, but an idea that I think is very exciting and sort of revolutionary is the question of primary prevention. Yeah. So people who are not sick, who do not have MS, but potentially have some risk, maybe some combination of genetic and environmental risk. Maybe they have a first-degree family member with MS or with other autoimmune diseases. Is there something that we can do to prevent MS from ever occurring? That's something that I think we're near to approaching as we identify genes that clearly do increase an individual's risk of developing multiple sclerosis. We're trying to develop something akin to a risk score, where we can say, okay, with this genetic profile and these things in your environment, we think your likelihood is XYZ, and I think we're close to being able to think about what kind of primary prevention strategies we could put into place. Our colleagues in cardiology have paved the way, right? They have taught people to stop smoking and to get their cholesterol checked and things like that. I want to see our management of MS move into that realm.
Yeah. One of the ways that I think we better understand how does MS start in the first place is looking at children with multiple sclerosis. Children are more similar than adults are, in a sense. They haven't had an entire life of exposures to various things that might be triggers for MS. So looking at our youngest people with MS is a way of getting us insight into where does this condition actually start and why. And so it's notable that this year is also a year that we had the first large, successful clinical trial in pediatric MS that's been run. This is a trial of fingolimod versus interferon. So 2 treatments, both approved for adults with MS, and the fingolimod here was superior to the injectable interferon, preventing relapses by over 80%, preventing MRI lesions extremely well. And we know that that's an important unmet need for us. Now, I know, pediatric MS might seem like a niche area, but there are pediatric MS specialists and pediatric MS centers, including at Columbia with Dr. Riley and with us
I'll
at
just
Sinai.
add that pediatric MS is rather rare. So I don't want the parents in the room to have a heightened sense of concern, but when we do see it, it can be really impactful. And the children have very strong immune systems. They also have a lot of plasticity and can bounce back from from damage pretty well, but we see a lot of inflammation in children with MS, and I think that dramatic difference that we saw in the clinical trial between fingolimod and interferon beta, there was about an 80% reduction in relapses and new lesions on MRI, and I think in part that's because the disease can be so inflammatory in children.
Mm-hmm. So I think we're going to turn from relapsing MS over to the next topic of interest, which is clinical trials and data in progressive multiple sclerosis. So this has, of course, been a huge area of emphasis in research in the last several years because we do have an abundance of treatments for people with relapsing MS, and we certainly need more of them for all people with MS, but in particular, the need for treatments in progressive disease, I think, is something that we all face every day. So this year, there's some interesting new data in a couple of different ways. So the first one we'll talk about is at the European MS Congress that just happened in October. Dr. Bob Fox from Cleveland Clinic presented the first data from a trial of a medicine called ibutolast, which is not one that we have approved in MS. It's a novel medicine. It's not an immune suppressant. This was a trial in people with both primary and secondary progressive MS together, and there was some good news from this trial. Dr. Riley's an investigator in it, so I'm going to let her start off, and then I'd like to hear what you guys think is needed in progressive MS.
I'm happy to speak on this. So we saw the primary endpoint of this study was an MRI endpoint, going back to what I was saying before about brain atrophy. In progressive MS, this can be even more of an issue, and the study found that there was a reduction of 48% in the rate of brain atrophy over the course of the 2-year trial. And ibutolast is a phosphodiesterase inhibitor. Maybe that doesn't mean much, but it's not an immune suppressant. It works in a very different way with the potential that it could be used as a companion therapy potentially in the future. And this was a phase 2 study, so it's a bit early, but I think based on this initial positive results, we'll likely see it go into phase 3 and potentially on into market if we see a positive phase 3 study.
It's very exciting to have a molecule for patients with progressive disease. Mm-hmm. What's so interesting is that this oral compound actually is used in Japan to treat patients with asthma and post-stroke dizziness. So not sure where the relationship is there. To see that there's some decrease in brain atrophy in these patients, hopefully that can lead to more clinical significance where patients might have less cognitive issues, fatigue, depression.
I also think that the side effect profile was very well tolerated, right, Dr. Riley?
So that's one. Another thing that 2017 will be, I think, remembered for in the multiple sclerosis world is the approval of the first medicine for primary progressive MS. This was ocrelizumab, approved in the spring after a positive, successful clinical trial in primary progressive MS. And how we define success here is preventing accumulation of disability. And the way disability is usually measured is, again, through those very sort of rudimentary things that clinicians do in the office. The data for ocrelizumab in primary progressive MS was reanalyzed this year, looking at perhaps some more meaningful ways of looking at disability. Rachael, maybe you can tell us a little about that.
Sure. Remember when I was speaking before about looking at different markers, and so they broke it up, the study up, and said, how did people do? And so they looked at what Stephen had referred to before as knee pad, right? How did people do who were taking the medication versus placebo? And they looked at people who, the MRIs and placebo, and how did they do? And overall, really taking those markers out and looking at them separately and then sometimes together, people who were on ocrelizumab did well. And that's what we really hope to see. So it's encouraging. I just want to echo that it was a big thing to have something approved for primary progressive. And so it's very much celebrated.
Yeah, I mean, it's rare to get a big bunch of neurologists and neurology providers excited. We're not the most dynamic and flamboyant group at times, but there was a standing ovation at this presentation. And that was in 2016. But I think that just from my point of view, taking care of MS patients, it's really wonderful to have something to talk about and offer in the progressive phase of the disease. So just from a personal perspective as a provider, we're very excited about this. And it's not perfect, and it's not a panacea, and it's not the right treatment for every single person. But I think just to get over that hump, there's a big difference from 0 therapies to 1 therapy.
Yep. Yeah, it's sort of, I think it paves the way. It shows us, in a sense, what success can look like for a new treatment strategy for progressive MS, and it sort of has allowed us as a field, I think, to do better and to design better trials and to look more astutely at progression and how we can treat it. I think that's also true for another medicine that we saw data for this year in secondary progressive MS, which is data from a medicine called siponimod in a trial called EXPAND. So you're hearing how these things are named: fingolimod, ponesimod, ozanimod, siponimod. These are all the same class of medicines that are fingolimod-like, that work in a similar way. But siponimod had success in a secondary progressive MS trial, preventing disability, preventing the co-occurrence of relapses. As Jong-Mi said, they can happen together, and preventing brain atrophy, which you've heard now in several different ways is an important thing we're trying to do, is stop the brain from shrinking over time. So this sort of succeeded in all those regards and is now going to be looked at the FDA.
It would be interesting to see how this plays out long term, to make sure there's not any serious adverse effects with this drug, but definitely it's very exciting to have something to offer to someone who is secondary progressive. It's a little bit of a gray area of when patients convert or move from relapsing to secondary progressive, but there are patients that clearly we know are in that secondary phase of their disease, and it'd be great to offer something.
I think in addition to medicines, to some of the questions that have come through on Facebook, what else can we do besides medicines is something that a couple of people asked. Arwa asked about vitamin D. So let's turn from just treatments and just drug trials to looking more broadly at health and wellness in MS, which I think matters across the whole MS spectrum, but is of perhaps the most, clear and present need in people who have some degree of progression or some degree of disability with this disease. How can we maximize people's well-being and function? So we have a couple of different topics we're going to touch on that we picked that were of interest. The first one is research into the microbiome. Quick show of hands in the room. How many people are familiar with this concept of the microbiome? All right, so a fair portion. I don't know if that's representative of our streaming audience at large, but you want to talk a little bit about what the idea of the microbiome is and then how it's now being looked at in MS?
Really, if you just break it down, we're now looking at the gut as part of the immune system. We're not just separating out the brain. We're saying, all right, well, actually the gut plays a big role. And in the gut, there are specific classes of these bacteria that live in our gut that develop actually at birth, and then things like receiving antibiotics, vaccinations, things can affect how that gut is formed and developed. And it looks like when they have studied this in mice model, that patients with MS have a higher level of a certain bacteria and a little bit lower level of another bacteria. And so this is very interesting because patients always ask, what do I need to be eating? What does my diet need to look like? Do probiotics help? These are all the questions that I think all of us face. And learning more about how the microbiome is affecting the disease or maybe leading to MS will help us in guiding patients to say, all right, maybe this is how we need to structure your nutrition. Maybe this is how we need to structure your environment so that you don't have relapses, you don't have disease progression. We're still looking into it, but it's definitely something else we can offer outside of just medications.
So don't be surprised if your MS provider asks you to contribute a stool sample. This is something that we have to figure out the answer here, and the way to do that is actually to get samples of stool and analyze the bacteria that are there, separate them out, characterize them, actually look at the DNA of the bacteria, and look at the genetic material. One important finding, I think, is the diversity of gut microbiota is really diminished in people who have MS and have other autoimmune diseases. So we don't know what that comes from, but it seems to be, one can identify that very early on, including maybe at the first signs of MS. And the kind of diversity that you can recoup from an over-the-counter probiotic is pretty minimal. Not to say that probiotics may not be helpful, they may, and they may be helpful in relieving some MS symptoms like constipation, but they are not providing the kind of incredible diversity that exists in the gut. One way that the importance of the microbiome has been demonstrated is in a mouse model of MS. If you take stool samples from individuals with MS and then transplant that stool sample into a mouse and then give that mouse MS, the characteristics of the individual from whom you transplanted the gut flora can to some extent be transferred to that mouse. Pretty amazing, I think. And so these are some proofs of concept. There's a lot more work to be done, and I'm not suggesting that people should run out and get, transplanted stool. But these are ideas that sound kind of off the wall and outlandish, but they're actually, they might not be so far off.
That's right. I mean, we're asked every day about what diet would be best for multiple sclerosis, and there's of course many books and articles and blogs about that. I think we don't know the answer yet as to what diet is going to be best for MS. I think it's probably oversimplified to think that one diet is going to be the right thing for the incredible diversity of people that have MS and the incredible diversity of the way MS can behave. So I just think just as simply as there's not one medicine that's obviously right for everybody with MS, there's not one diet that's obviously right either. And we think about the way diet affects MS as affecting the health of the brain and the nervous system, but it also affects the microbiome. It affects the bacteria that are in our body and the immune system organ that is the gut. And so in a sense, there's the microbiome and the gut are the mediators between diet and MS, and they're almost certainly going to play an important role. We did a little bit of work on this sort of broad topic of health-related behaviors and good MS outcomes at Mount Sinai. It's my colleague Alana Katzand's work, which she presented this year. She's doing a diet study in MS, which is not done yet, so we don't have that data, but it is a randomized diet study. So people who go into it have to be willing to commit to the diet that they are assigned in order to really compare how does one diet perform versus another, which is something that no diet book or other recommendation has yet done. So none of those are ever controlled studies, which makes them very hard for us to interpret. This is a controlled study. We'll see how it goes. It's been difficult, though. It's hard to make people agree to a diet that they're assigned to do and have them stick with it. But she's already shown a little bit of data that good health-related behaviors, maximizing sleep, keeping heart rate and blood pressure under control, cholesterol down, not only helped people with MS have better outcomes, but it also helped to keep the brain thick in areas that we want it to be thick and not shrinking away. So that was data that she showed this year. Positive health-related behaviors, not just making people feel better, but actually changing aspects of how their brain health is. And I think that's a great example of where this field is going.
We'll need that, controlled and randomized study to show that the directionality of that association. But I think it's certainly, and these are all positive behaviors for your general health too. So there's no reason to not quit smoking. There's no reason to not, eat real food rather than this tremendously processed food that people want to sell us. So I think that it seems like low risk to try to improve your health-related behaviors. Yeah. And I think it'll be very interesting to watch how these controlled studies pan out.
I mean, part of the way we think that this works in MS is by boosting the nervous system's own reserve. And so this concept of brain reserve and neurologic reserve has gained a lot of interest in our field. I want to hear what all you guys think about it. I'll tell you my sense is the following, that on a normal day, we get up, we go about our business, we do our thing, but we're not pushing ourselves to our maximum possible abilities in any way on a given day. We're not thinking as hard as we possibly could. We're not working out or moving as hard as we possibly could. We're not stressing our balance systems and walking on tightropes or some equivalent to that every day. Don't try that to the live streaming audience. But we have different amounts of reserve that we're not always tapping into. And I think that a lot of our research and other areas of research are looking at how can we boost those things? How could we build our levels of reserve? I'm wondering if you guys can share. Do you talk to your patients about that? What aspect of wellness do you think that speaks to?
Yeah, I mean, I think there's a kind of a fine line where we don't want to push our patients too much, where they're uncomfortable and they feel like they failed because they haven't met our expectation or their own high expectation. But certainly I think reserve is not just being on drug therapy. It's not just coming to the visits and being vigilant about your neurologic clinical care, but it's also looking at what we've just been talking about, your wellness, what you put in your body, emotional wellness, having a support system around you and not being so isolated also helps with your reserve. It's not just physical, but what's emotional, spiritual for you. So these are things we certainly talk about in our clinic. Certainly we want to wrap it up, but it's very nice that there's so much now looking at reserve instead of just focusing on medication. Yeah. We've kind of come back around to looking at wellness and what does wellness mean for patients with MS.
That's right. Rachel, do you have
I'll just add, sometimes a lot of reserve really came out initially with cognition and cognitive reserve, and I think there was correlation between education and outcomes and looking at that. And to me, it makes sense because think of how we grow up and we're in school and then we get to a place where we are plateauing, right? Because we're doing the same things day after day. We're learning, and then we reach, depends. I mean, for Dr. Riley and Dr. Krieger later,
many years later.
Many years of school later. But then we get into our groove and we're not really challenging and learning new things. And so with my patients, I always talk about the importance of kind of working that muscle and learning. Even going to things or learning, when we were getting ready to speak to you, there are so many posters and abstracts presented, which actually people should feel really hopeful about because there's so much work being done in this field to really try to have a good handle on it. You have to you're going in and you're studying it and saying, have I looked at all the aspects of that? And so I would I would encourage you to do that, to keep challenging your brain, to keep trying to learn and building that reserve.
I agree completely. I mean, in the topographical model, I refer to this as keeping the tank full, trying to fill up the amount of reserve that we can to keep the disease itself submerged and compensated for. And I think that's a good goal all around. Well, we have, according to Facebook Live, we have 2 minutes. And I want to give everybody presenter's choice. So briefly, a thought of one thing of those thousands of posters and abstracts, Rachel, that you mentioned. What's something that struck you this year?
So I'm not sure if you all heard, we've been using this data of prevalence of MS in the United States, and we constantly say 400,000 people, but it's so out of date, right? Because everyone knows someone who has MS, and it seems much more prevalent than that. So the National MS Society pulled together advocates and researchers and tried to really define how many people in the US are living with MS. And they did a pretty comprehensive approach. And they're estimating that in 2017, about almost 1 million people are living with MS. And so I know that's not great. We don't want more, but we knew there was more. And so to really know that how prevalent this disease is and that we can use that number to help define services and health services that for people living with MS.
That's great.
Sorry, I felt really pressured with
So I'll give you my very brief presenter's
Yes.
choice. So many of you may have heard of something called CCSVI. This is a concept that has been around for about 10 years. It was proposed by an Italian vascular surgeon who proposed that MS is not an autoimmune disease, and in fact, if we open up blood vessels to the brain, it could be solved. It sounded tantalizing. It sounded too good to be true. He named it the liberation procedure, and thousands of people went and paid a lot of money to have this done. But the problem was the data wasn't there yet, and it was studied then over the ensuing years by multiple investigators that over and over again failed to replicate those results, failed to show that CCSVI was a real thing in MS and that doing this procedure would be helpful. And it caused a lot of commotion because I think people in the MS community wanted so much for this to work, and clinicians were often in a position of saying, we're not sure yet and this could cause harm. And that sets up a friction that I think played out over the last 10 years in our field. So why am I bringing this up now? So it's one thing if someone has a hypothesis and other people kind of can't show it. But it's something else if the person who originally came up with it does the kind of study that we're all asking for, does a real controlled trial, and then finds that it doesn't work. And that's actually what happened this year, that Zamboni did finally finish a real study of this CCSVI procedure. And it was published in a very preeminent journal in our field that it did not work. Now, usually negative studies don't get published in big journals like that, but I think that this was an example of somebody sort of finally doing the right thing in a sense and putting the data where the idea was. And I think it's important to know that it was negative and that there's no data to suggest that people should have this procedure. But I think more importantly, what concerned me about it was the rift that got opened up between people with MS and the societies that support this field and all of us who are trying to get the best outcomes for everyone. And I hope that this is the last time that happens. I'd like to see more of an alignment around the idea that we need good data if we're going to recommend things to people so that we know what the risks and benefits are, so that we know what the harms are. None of our medicines are harmless. It's on us to talk about those risks, and we need to make good decisions based on good data. So my hope is that that rift will not happen again, and that we can be sort of more aligned around what we're all trying to do. So that was my choice for this year.
I was very interested in comorbidities, and so there was a poster that was presented on insulin resistance. We do have patients who have multiple comorbidities, and they did find that patients who had MS did have a higher risk of insulin resistance. Not sure how much of that impacts long-term disability, but anyone who's diabetic, we do notice that if you're diabetic and you have MS, if your blood sugar is not under control, your symptoms will worsen. And so there's definitely a correlation there.
Oh, and I selected a topic near to my heart, which is this association between some of these health behaviors and MS outcomes. So a look at the NARCOMS database showed that there was an association between healthy diet, again, real food, not fake food, and better outcomes with MS, meaning less disability. And there was also an association between other positive health behaviors like not smoking and being around your target BMI and taking on some degree of physical exercise, and a decrease in MS-related symptoms, including fatigue, pain, and depression. So I thought that was exciting. We don't know which way the associations are moving. We need those controlled studies to figure that out.
But I think what's nice about all of these things that we've selected is they sort of paint a kind of coherent picture about the number of people out there with MS, the need to both treat people with medicines effectively and also really manage lifestyle, comorbidities, overall health, and try and bring about those sorts of outcomes. So I'm going to stop there. It is 12:04 p.m. Eastern Time, and I want to thank everybody who's here in the studio audience, as it were, for coming and being here with us, and we hope very much that you got new information out of this panel discussion. I want to thank everybody who's tuned in from the Facebook live stream, and Really appreciate your questions. We tried to get to as many of them as we could. I know we probably didn't get to all of them, but thank you for listening in. And I really want to thank our panelists for being here. Let me put their names up on the screen if I can. Oop, well, there it is. There's their names on the screen. So to Jong-Mi Lee, to Claire Riley, and to Rachael Stacom, really grateful to all of you for being here, and thank you guys very much for watching today.